session. I'm accompanied by my co-moderator, Dr. Schwab, and myself, Dr. Arapali, and we'll be starting the translational research in age-related macular degeneration and diabetic retinopathy session. I'll be the first speaker, so. Thank you. All right, so the IMAGINE study is something I'd like to talk about today briefly. It's a study that we did at Cleveland Clinic where I did my fellowship, which basically looked at patients with diabetic macular edema and also assessed the amount of cytokines in their aqueous. And we looked to see if they responded to therapies, if their cytokine levels changed or if they were predictive of change. These are my financial disclosures. So a little bit of background. Diabetic macular edema is the most common cause of visual decline in diabetics. We know that diabetic macular edema is multifactorial. There are multiple cytokines that are involved, but we usually hone in the retina community on VEGF, and most of our drugs target the VEGF pathway. But there's no robustly validated mechanism or biomarker to differentiate which patients with DME will respond to anti-VEGF therapy at baseline and which of those will not. And we were interested in this because we realized in our own patient population that about 30% of patients were not responding the way we would like to the initial anti-VEGF therapy. So we assumed there are likely alternative inflammatory-based avenues. So the purpose of this was twofold. One, to characterize the longitudinal aqueous humor cytokine profile in patients with DME that were being treated with intravitreal ranibizumab. We also wanted to look at which cytokines were predictive of anatomical resolution. We then looked to see higher order imaging analysis on OCT and ultra-wide field fluorescein angiography to see if there were features there that were predictive of anatomical resolution as well. Our patients were obtained through a post hoc analysis of the DAVE study, which was a 3-year prospective randomized trial that looked at ranibizumab compared to combination therapy, meaning ranibizumab plus targeted retinal photocoagulation. Patients received 4 monthly doses of ranibizumab before starting monthly visits and transitioning to PRN. We obtained baseline aqueous humor samples at baseline, month 3 and month 12, and ran their analysis. So we looked first at higher order OCT analysis. This was through a software that was developed through retinal physicians at Cleveland Clinic that put scans through an automatic segmentation in order to pull out key characteristics, including measurements for intraretinal fluid, subretinal fluid, the ellipsoid zone, and RPE. There were also scans that we took based on width from the fovea, so we took a pan-macular scan, but also central subfield scans as well. And we also looked at other types of measurements as well, including ellipsoid zone health or thickness. Moreover, we also looked at specific fluid extractions, so we extracted measurements based on automated segmentation, looking at intraretinal fluid volume, subretinal fluid volume, and retinal fluid index. So this is an example of the images as they were segmented through this technology. So essentially, you'll run an OCT through the segmenting platform. Blue will highlight the areas of intraretinal fluid, green for the areas of subretinal fluid, and then those areas are taken and calculated. These are again assessed by 2 independent reviewers to make sure the segmentation is correct. Based on these and their OCTs that were obtained at definitive time points, patients were categorized as different types of responders. So we had 4 groups. You were a super responder, meaning you responded very, very well to VEGF therapy, and you had an over 80% reduction with 1 injection. We also then had early responders. Those were people who had the same type of reduction, but within 3 injections. Slow responders, meaning they reached that 80% reduction, but it took longer, so up to a year. And then we had about 20% of non-responders or minimal responders, meaning they did not get better with therapy the way we would have expected for the first 3 groups. We then tied these biomarkers to cytokine analysis. Now we ran a cytokine plate of at least 50 cytokines. This is just highlighting the few that stood out and were repeated among multiple patients. What we found is that patients who were super responders had a significantly higher level of VEGF. That was not unexpected, given the fact that they're responding to VEGF therapy. We also found that they had lower MCP1 levels compared to patients who did not respond. This remained true when we divvied out the super responders and responders together. We also found that slow responders showed higher levels of ANGPTL4. This is an example, again, showing us a super responder versus a non-responder, and you can see that with the higher levels of retinal thickness and interretinal fluid, these are the patients that had higher levels of VEGF. You can also see lower here, again, a figure delineating the fact that super responders had significantly higher levels of VEGF, while they had significantly lower levels of MCP1. We also looked at cytokine levels in terms of outer retinal thickness, so ellipsoid zone attenuation or ellipsoid zone to RPE volume. There were various cytokines that played out here as well, including another ANG family cytokine, which we saw earlier as well. One of the other things that we did was we also tried to correlate this to ultra-wide field fluorescein. The ultra-wide field fluorescein analysis was done through the same sort of segmentation technology that we have at Cleveland Clinic. It incorporates de-warping our fundus photograph that was taken on Optos Photo to process the scans. And then various levels are segmented out, including areas for leakage and ischemia and microaneurysms, which I'll show. These were analyzed in early and late frames, and they were done at baseline, month 3, and month 12. So this is an image showing the automatic segmentation. So on panel A, you can see that we're highlighting the areas of ischemia. On panel B, the areas of leakage, and on panel C, the areas of microaneurysms. These are then quantified based on the scan that we chose. So depending on how far out from the radius of the fovea we elected to use, there were different zones that we measured. Then similar to the OCT results, we did the same thing with ultra-wide field. We looked to see who were categorized as responders or non-responders. On terms of ultra-wide field FA, we found that we had a pretty high level of responders for microaneurysms and leakage responders. So for microaneurysms, we wanted a 25% reduction by 12 months. For leakage, we wanted a 50% improvement in leakage by 12 months. And similarly to the OCT study, we also attempted to correlate cytokine levels to the ultra-wide field analysis. Again, we saw some of the same players be important here as well as what we saw in the OCT. So we saw increased pan-retinal leakage correlated with VEGF, the ANG family, and also interestingly IL-6, which has become important in uveitis studies recently and has been implicated in many inflammatory conditions and diabetic macular edema. We also found that ischemia was related highly to TIMP1, which is another alternative cytokine that we started paying attention to once looking at this. And then MA is also correlated to MCP4 and PCAM. So in terms of an overall summary here, this is still an initial small study. This is a small number of patients that we were looking at, but it started to assess what levels of cytokines we could be missing with our typical anti-VEGF therapy. The things that we found that stood out to us is that IL-6 came out quite a bit in diabetic macular edema and leakage throughout the fundus, which is not totally unexpected, again, given the fact that we see this in uveitis, and we suspect that diabetes has a strong component of inflammation as well. ANGPTL4 also was prevalent in OCT macular edema and also leakage, so also points to another area that we could experiment with later in the future. One of the other things that I found interesting is that DME was also associated with MCP4 and MCP1, which we know are correlated to extra matrix material. And so their dysregulation makes sense because it probably links to an increased level of DME as well. So again, this is all highly exploratory. This is not a large enough study to change management patterns at this point, but does point to the fact that there are several other cytokines within this pathway of DME and leakage and ischemia that we could likely target in the future. Thank you.
Yeah, any question?
Great talk, Shruti.
Thanks.
I think that's very interesting that you showed these other factors responsible for DME. And as far as retina is concerned, we are too concentrated just giving anti-VEGFs.
Mhm.
So do you think that, targeting some other cytokines and the MCP, maybe we could develop some local therapies against these and use it as a multifactorial approach?
Yeah.
To be better?
100%. I think that this speaks to the fact that there's something besides VEGF, just to your point. We've started utilizing faricimab in the United States, which has this bimanual pathway, and we are seeing that in some patients it has a better response than traditional anti-VEGF therapy. So there might be something there, but I think that there are other opportunities to incorporate pathways as well.
And does steroid have any effect against these?
I think you would think that it would. So in uveitis, IL-6 is very high, and steroids work beautifully for them. So yes, steroids, we often, when they fail anti-VEGF, depending on what insurance mandates for us, what we can move to next, sometimes we will do an Ozurdex or a steroid injection to kind of quiet down all these other markers.
And have you measured the cytokines and MCP in the steroid injected
That's
eyes?
a very good question. No, we haven't, but a very, very good point.
Dr. Shruti, what are the things in the pipeline just now in the near future as alternatives or additional sort of complementary treatment with anti-VEGF? So what are the things in the pipeline just now which could be promising?
So so I practice both retina and uveitis, and so what I'm interested in is the IL-6 markers. So IL-6 has become very popular in terms of clinical trials. We're in phase 3 trials now. And it's showing very promising results. And I do think that once we have it on label for uveitic macular edema, we'll also be able to make the argument for diabetic macular edema. And then for us as well, steroids have been so instrumental that I think we're moving away from larger implants, but smaller implants that are longer acting will be very helpful.
Okay. This is Kentaro Nishida from Japan. Thank you for your great talk. And you showing a very beautiful picture of the wide field FA, and ischemic area is automatically identified by using the software.
Correct.
Is it commercially available, or your own? So it's a commercially available software?
It is not commercially available. So it was designed by 2 retinal physicians at the Cleveland Clinic with our AI department. So it's only used at Cleveland Clinic.
Yeah, that's very nice. Thank you.
Thank you, Dr. Shruti. And I think the next talk is on plasma ephrin A1 levels. Is Professor Bolai here? Plasma ephrin levels in cohort of diabetic retinopathy patients. So I think possibly the next speaker has not been able to make it to the session. So now we have Professor Kentaro Nishida from Osaka in Japan, and he will be speaking to us on the morphology, fundus autofluorescence, and retinal sensitivity of photocoagulated lesions in proliferative diabetic retinopathy.
Thank you, chairs. So it's great honor to be here, and thank you for program committee to invite me to show my work. And the pan-retinal photocoagulation is golden standard for severe ischemic retinal disease. However, there is few studies that investigate the sensitivity and morphologic change of photocoagulated lesions. Purpose of this study is to evaluate the sensitivity and morphologic change of photocoagulated lesions with various fundus autofluorescence by microperimetry and OCT. Patient with proliferative diabetic retinopathy undergone pan-retinal photocoagulation PRP more than 1 year ago. Best visual corrected visual acuity is equal or better than 0.8 in decimal were included, who visited Osaka University Hospital from April 2019 to October 2022. Fundus autofluorescence FAF of photocoagulated lesions were evaluated by ultra-wide field retinal imaging opto-Silverstone. Photocoagulated lesions classified into 5 groups by the condition of fundus autofluorescence. Group A is a lack of FAF, and Group B is a diffuse FAF. Group C, a center dotted hyperfluorescence with diffuse FAF background. Group D is a center dotted hyperfluorescence with no FA background. And Group E is a control. And I'll show you a representative case of this study. The 51 years female and well-controlled diabetes and good visual acuity. And we examined this lesion, and we evaluated the three lesions in this patient. And upper is a lack of FA, so group A, and lower one is a diffuse FA, group B. And we confirmed there is no severe ischemia around these lesions by OCTA. And microperimetry examined in this patient in the twice a day and different day. And score, the edge of the lesions have no consistency, but the center of the score is consistency. So the average of the 4 scores is retinal sensitivity as each lesions of this patient. And the OCT shows group A as a lack of easy line, and group B shows a little bit easy lines lack, but it remains an easy line. And demographic data is a male is 11 and female is 8, and total eye is 22, and age is 62.5, and the best corrected visual acuity is 1.02, and the HbA1c is 7.1, and type of diabetes is type 1 is about 16%. Duration of diabetes is 25.9. And the result of retinal sensitivity of the photocoagulated lesions and the lack of FAF, and background is a lack of the FAF. Group A and D is a low score, but diffuse FAF and the diffuse FAF background, group B and C, is a better score than the group A and D, and worse than the control group E. So there is a statistically significant. And the morphologic change in the easy line in the photocoagulated lesions is a group A, and group D has a lack of easy line, tend to easy line. So, but group B with FA, diffuse FAF is tended to have the remain easy line. But the group C is a small number, and there is no statistically significant. And fundus autofluorescence after photocoagulation is already reported. Very early phase, a few hours later, the photocoagulation is a hypofluorescence due to edema of retina. And early phase is a few months later after the photocoagulation is a hyperfluorescence due to dysfunction of RPE. And late phase after the 1 year later is a hypofluorescence due to the absence of RPE and the pigmentation. And fundus autofluorescence is plus is RP remains, and sensitivity of photocoagulation lesions is a photoreceptor remains. And the regeneration of the photoreceptor after photocoagulation is reported in animal experiment. And representative sensitive intense lesion produced by 100 millisecond pulse 4 months later, the scars occupied the 36% of the initial lesions, and very weak lesions after the 4 months, the almost destruction is cured. So the authors speculated that the migration of the photoreceptors around the photocoagulated lesions. And meaning of the center dot hyperfluorescence is process of the changing of FA after photocoagulation. And group C will go to the diffuse FAF group B, and group D will become the group A. And the importance of fundus autofluorescence of photocoagulated lesions. Purpose of retinal photocoagulation is to destroy photoreceptor, and remaining diffuse fundus autofluorescence of photocoagulated lesions implies existence of photoreceptors. Strong photocoagulations are needed to achieve photocoagulated lesions without fundus autofluorescence for severe ischemic disease like neovascular glaucoma. I will show you the typical case in which this result applied to the clinical practice. The 53 years old male, well-controlled diabetes, hypertension, and has a renal failure, and both PDR already performed PRP, and he has a vitreous hemorrhage in his right eye, and vitrectomy and cataract surgery and additional PRP were performed. After 10 months later, the intraocular pressure getting higher, and 5 months later, it's getting more higher. And neovascularization is present at the 27-degree angles. So he refused to have an anti-VEGF injection because of its cost, and with the anti-VEGF injection, we need the additional PRP as a definite therapy. So we perform the PRP. So the FAF image will help us. We reported the impact of the photoreceptor density on the PRP, and the rod density is the highest around the vascular arcade, and that is an important target for PRP. And from this image, the PRP around the vascular arcade is insufficient, so we added the PRP there as well. And 1 week later, the neovascularization was diminished, and with the 2 eye drops and the intraocular pressure is well controlled. And total for additional PRP and were performed, and with 2 anti-glaucomatic eye drop were continued. And 4 months later, so the it's stable and no additional PRP was needed. So how much PRP was performed? So I want to propose the photocoagulation index to quantify the intensity of photocoagulation. Photocoagulation index is the ratio of the total photocoagulated regions to the whole retina. So for example, PDR without NVG and with NVG. So the FA and is different appearance. So we use the software to calculate the all total retinal photocoagulated area automatically, and we divided this total areas. So the 20.2% is a patient's photocoagulation index, and this is a 44.7. So the patient has twice as more intense therapy were performed. So we are further investigations ongoing, so using the photocoagulation index. So the photoreceptor in most photocoagulated regions with diffuse fundus autofluorescence retain their morphology and function. Thank you for your attention.
Thank you for a very interesting talk. Any questions, Alan?
So you propose that in cases with neovascular glaucoma,
Yes.
we should be doing very densely packed laser.
Yeah.
And maybe repeated lasers till the pressure comes down.
Yes, I think.
How do you compare this versus the cyclocryotherapy in certain intractable neovascular glaucoma?
So just a moment.
The
What?
cyclocryo?
Oh, cyclocryo.
Yeah, in certain intractable neovascular glaucoma.
Okay, so that's so. First of all, the glaucoma begins at normal tension, and if we balance the production of the acronemus humor, maybe it's a one option, that therapy, but everyone has a micro, so that's kind of pulse therapy. So that is one option, and this one is one option, I think.
Yeah, just to interject, I think possibly we're talking of an extension. It's stages in which we're doing it. So naturally, if the patient first presents to us, we would like to tighten up the PRP as much as possible. And of course, in this patient, they couldn't, but anti-VEGFs would be a very important additional part of the treatment. And then, of course, despite if everything fails and despite all that, the pressures still continue to be high, then of course we have the option of cyclocryo or DLCP, cyclophotocoagulation. So I think we would probably sequentially.
I completely agree. That's the same protocol that we use as well.
The other interesting thing I think was possibly I was just thinking back for the pre-anti-VEGF era, and I think in those times we were probably lasering retinas much more intensively than we do now. And so I have a feeling, of course, we don't have a study to substantiate this, but I have the impression that this post-vitrectomy and post-PRP laser, neovascular glaucoma earlier used to be not so frequent, and now we are seeing that much more. So possibly it would be because we are not intensively lasering these eyes and leaving a lot of hypoxic retina still there. So, and the question about field and this thing restriction is, I think, in some ways overstated. I theoretically yes, but we have so many patients who were lasered from arcade to aura, and they are maintaining 6x6 vision. They're 30-40 years post laser and doing everything, driving, playing tennis, doing everything without really having much problem. So I don't think we should be really scared of doing more laser where it's required.
Excuse me, ma'am.
I would like to add to this. Cyclocryo, usually it is the last resort. So before that, we can consider doing deep scleral trabeculectomy with prior anti-VEGF, then trabeculectomy. Then once the cornea gets clear, we can do additional PRP. Cyclocryo is the very last resort. Thank you.
Some cases they like to do the valve, the glaucoma valve procedures also.
Okay, thank you.
Okay, next up we'll have Dr. Wang, who will be discussing injectable anti-inflammatory supramolecule nanofiber hydrogel to promote anti-VEGF therapy in AMD. Is Dr. Wang with us? Okay, so we'll move to the next one. Our next speaker will be Dr. LA, who will be discussing newer therapies in AMD, ways forward.
Thank you, Dr. Shruti and Dr. Shroff, and I would like to thank the APO for this kind invitation. I've been given the topic of new therapies in AMD way forwards, and I do not have any financial disclosures. There are over 100 molecules which are being researched, so it's a huge topic, but I'll just give you a brief overview of a few of these and exploring the future. No limitation of time. Exploring future therapies for AMD, I think basically there are three main therapies which are being researched. That is the gene therapy, the stem cell therapy, and we also have the novel pharmacological approaches. So I think it's not moving forwards. Yeah, it's not moving up. Yeah, now it's, thank you. So coming to the upcoming gene therapy treatments, we have various therapies in the wet AMD as well as in the dry AMD. And if you see, there are a few molecules in the wet AMD, and I'll be briefly going through these. And all these therapies basically are trying to address, to reduce the treatment burden which is there in the current anti-VEGF era. So coming first to the wet AMD, there's a molecule that is being developed by Regenx Bio. It's an RGX-314, and it uses the AAV8 vector to deliver the genetic code that expresses the monoclonal antibody fragment, which is similar to ranibizumab binding and neutralizing the VEGF. It is also designed to be a one-time subretinal or a suprachoroidal drug delivery system. And it basically reduces the leaky blood vessel formation by giving the ocular cells the ability to produce an anti-VEGF Fab molecule. A randomized control phase 3 clinical study is underway, that is the EXCENT study, and this is a brief design of the study. I'm not going into the details. Second molecule is the ADVM-022, which is developed by the Adverum Biotechnologies. It basically uses a novel vector capsid, the AAV2.7M8, which carries the ubiquitous expression cassette encoding for a codon, which is optimized cDNA of the anti-VEGF aflibercept protein. So this is again against the aflibercept, and the initial study showed that the best corrected visual acuity was maintained and the central retinal thickness was reduced and remained stable at 2 doses with greater reduction amongst participants with a baseline thickness of more than 300 microns. Most importantly, it also substantially reduced the treatment burden in patients requiring more than 9 anti-VEGF injections, and almost 90% reduction in those annualized VEGF injection in both groups. So basically, they concluded that it was well tolerated at both doses and led to a significant reduction in the treatment burden of these patients. Another molecule, which is the 4D150, which is designed by 4D Molecular Therapeutics. Again, it is used as a single dose intravitreal AAV vector, and it carries 2 transgenes encoding aflibercept as well as an miRNA sequence targeting the VEGF-C. Basically, it is the first gene therapy which is designed to inhibit all the 4 VEGF-related molecules, that is the VEGF-A, B, C, and the PIGF. Now coming to the dry AMD, one of the molecules is the JNJ1887, developed by Janssen Research. Again, it is an AAV2 gene therapy. It is designed to increase the expression of a soluble form of CD59. It basically directly blocks the MAC, which is the final step of the complement system linked to the formation of geographic atrophy and VEGF upregulation. Again, this is designed as an intravitreal injection, basically to treat patients with geographic atrophy secondary to dry macular degeneration. Another molecule which is researched by Ocugen, which is a broad spectrum gene agnostic approach. It is Aurora, which is a nuclear hormone receptor. It plays a role in the development and function of the rod and cone photoreceptor cells. And basically it regulates the genes and the pathways involved in the onset as well as the progression of AMD. And if you see the picture on the right, it's directly to the lipid deposition, which causes the drusen, the inflammation, which causes the CMV, also the complement activation, as well as the oxidative stress. So basically, the Aurora regulates the genes involved in all these mechanisms, as is shown in the picture onto your right. Coming to various pharmacological pathways, I think one of the most promising, exciting ones in the near future is the Duravyu, which is the vorolanib intravitreal insert. It is basically a tyrosine kinase inhibitor, and it selectively inhibits all the VEGF signaling pathways. And it is used as a biodegradable sustained intravitreal drug delivery system. It reaches the target tissue at therapeutic levels within hours of administration, and then delivers a continuous dose over a period of 6 months. So the DEVO2 is the largest tyrosine kinase inhibitor trial to date, and with one injection, it maintains stable visual acuity and a strong anatomical control. Very interestingly, 63% of these eyes were supplement-free up to 6 months after dosing, and also substantially reduced the treatment burden, which we are all very concerned about. And it was very well tolerated with no related ocular or systemic SAEs. A very interesting concept of what is known as the armor lipids is being developed by a company called as BioGiva. It has created bioengineered omega-3 as well as the omega-6 fatty acid lipids, which are up to 30 times more resistant to oxidation. And because of their widespread bioavailability, they are designed to target the retinal, neuronal, and the systemic diseases involved in the oxidative stress and chronic inflammation. And the initial study showed that the dose-dependent, it had protection against the retinal atrophy with complete protection at more than 50% levels when given orally. It reduced the toxic byproduct accumulations, hence reducing the formation of soft drusen, It also suppressed the inflammation and slowed the geographic atrophy expansion, and also provided neuroprotection. I think there's going to be a lot of talk and research on the neuroprotection and neuroenhancement, particularly for dry AMD. So neuroprotection is basically cell survival, and neuroenhancement is basically the increased cell activity or functionality. And both these are done by blocking the cell death signals. And there are so many drugs and pathways, that is the complement inhibition, the CNTF, the integrin peptide integration, the mitochondrial membrane stabilization, the macrophage repolarization, the fragment apoptosis stimulator, the neurotrophic product of the stem cells, and most recently, very exciting, the photobiomodulation. So just to name a few drugs, this is the Restoret, which is acts against the activation of the WNT signaling pathway, the AVD104, which is used in geographic atrophy. It causes inhibition of the activated macrophages and the complement pathways. There is a drug known as gilteritinol, which is again very effective for geographic atrophy. And a very recently published article which shows that interesting use of eye drops, basically the PEDF peptide drops, which was found to be neuroprotective in the mice, and soon the clinical trials are going to start in the humans. Very interesting publication recently has come out with the use of the photobiomodulation in non-exudative dry AMD, which basically uses a light delivery system and also a synthetic opsin which restores vision in patients with severe retinal degenerations. I feel that ultimately it is going to be combination therapy. We have to integrate the gene therapy, apply the stem cells, also administer the pharmacological agents to improved outcomes. And this is just a brief overview of all the therapies that are being researched at various levels against the AMD. Just on a lighter note, maybe in the future, we would have a retina bank with us, where we'll go to the retina bank, and whichever problem we have a prescription, and we'll get a retinal implant, hopefully causing restoration of the vision which is lost. And most importantly, teleportation, because I'm sure it's not going to be available all over the world. We could have the teleportation going from India to maybe a lab in California, and can teleport our patients to get these effective medications in the future. Thank you very much.
Thank you. Does anyone have any questions? I can start if there aren't. So this was a very excellent talk. I think there's so many drug therapies in the pipeline are coming that are going to be or already are available to our patients. When you were reviewing these dry AMD therapies, did any of them stand out to you in particular as the most promising? And then did you find that they used certain imaging techniques to monitor the progression of the disease, like autofluorescence?
Yes, I think for most dry AMD trials, I think autofluorescence is proving to be one of the best imaging modalities, not just to decide which patients, but I think the response to the treatment. I think that is going to be very crucial when you study the autofluorescence. And probably like your lab or Shita's lab, you might have some softwares which would come out to help us study the autofluorescence analysis in details, because that is going to be very important. I mean, just reading the autofluorescence like we do in clinics now, it might not be very helpful. We'll be needing a lot more softwares which could generate us the results immediately.
Dr. Shruti, in India, we really haven't started or do not have availability of any of the drugs for dry AMD. I think it's possibly a combination of the cost and the fact that results have also been rather equivocal, and there was these issues of the setback because of some of the eyes getting inflammatory reactions. So how prevalent or how common is treatment for dry AMD now in the US? And I would also request Dr. Nishida's experience in Japan. Are you treating eyes with dry AMD?
Yeah.
Is it available in Japan? Is it approved for the use in Japan? Like, not yet.
We have it available. It depends on your center. So most of the academic centers do not utilize the medication because of the inflammatory effects and the lack of convincing data that it prevents real spread. The reason I was asking about imaging is because in some of these studies, when they analyze the autofluorescence to look for progression, there's some people in the US who believe that we're simply keeping that rim of hyperautofluorescence or dying cells alive for a little bit longer, but not truly stopping the progression of the disease. But on the other hand, if you're in private practice and you see a lot of patients on a daily basis, they offer it, but we just don't at Emory.
What do you think about the concept? I think we're too much, into imaging.
Mm-hmm.
I think there's loss to vision. I think there are a lot of aspects of vision, particularly the contrast sensitivity and the reading speed.
Mm-hmm.
And even though the vision gets stabilized, and if you see that the area of the geographic atrophy doesn't expand, patients still complain to us that, I was reading quite well in this amount of light, but now I'm finding a lot difficult. And you do the imaging, and it's still the same.
Right.
So I think there's a lot more to than just the imaging. What do you think about that?
I totally agree. I think the necessity of autofluorescence came out for the clinical trials as an endpoint, but truthfully, I don't know that it was the correct endpoint. I think there are other things like yours pointing out that can be measured as well.
Thank you for your great talk, and so very broad talk, so very, very interesting. And so I maybe missed the names. DAV102, it's a clinical trial is ongoing, and you showed the 6 months after.
Yes. Yes.
That agent will continue. Effect is last more long time.
So it has to be given every 6 months.
Oh, every 6 months.
Yeah, so initially you have to give 3 doses of aflibercept, and along with the 3rd dose, the implant is given, and then it is repeated after 6 months.
And implant will be dissolved
Yes,
itself?
yes.
6
months.
Okay, thank you.
Right. I think they are starting a global study very soon. Yes. Thank you.
Thank you, Dr. Ale. So I think with that was the last talk of the session. Unfortunately, 2 of the speakers could not be with us for various reasons, and anyway, I think we've had a nice session, and it's been a good learning and interaction, and so I'd like to thank Dr. Shruti, Dr. Nishida, Dr. Ale, and all of you who are present. Thank you for your attention and participation.